kiddos. Welcome back to me. I've been gone for about a month and a half now. We're doing a laparoscopic assisted gastropexy in a dog, big Bernese mountain dog. So if you haven't already done so, please subscribe to our channel. Make sure you turn on notifications. Can you pull the prep piece back for me, please? So we used to do the initial incision with the scope just by putting in a Verres needle into the abdomen and then insufflating. And then once it was insufflated and you got all the organs out of the way, then we would put other instruments in. But what we found was that there's a fairly high risk of perforating the spleen with your initial instrument placement or port placement. So now we do what's called a modified Hassan procedure, which is where we cut down onto the abdominal wall really carefully, and once we get into the abdomen, we then once we make a hole in the abdomen, then we put our instruments in, and there's a much lower risk of damaging the spleen, because the spleen's going to be sitting right in the way here. So I'm just doing like a little, almost like a grid approach. I have to be careful not to make my hole too big, otherwise we're going to have leakage of CO2 around my port. So I'm right on the linea alba there. And we'll grab onto that with some towel clamps. Just lift up on that for me, please. And that one. Okay, so that's in the abdomen now. There's some guts there. And now I can take my trocar. So we usually do it with a big trocar like this, but where is that here? So we're taking the trocar out, and just lift that up for me, please, and then we'll just advance it right into the abdomen. Like that, and so that's a lot more delicate. So we can take all of this stuff out now. Go ahead and remove that one. Get our gift. So gastropexy is, so large, deep-chested dogs have a tendency to twist their stomach. And when they twist their stomach, it's highly fatal. Look at that, please. Highly fatal, and so we do a procedure to prevent the stomach from twisting. All right, so we're going to have the insufflator turned on and everything plugged in.
Set at 11.
Yeah, that's fine. And then go ahead and turn on the light, please. All right, so that's gotten some crap in the way. Sure. So I've got abdominal contents in the way here, so hold on to that, please. And you've got the insufflator turned on? Okay. And that will plug into the side here. Yeah, that's fine. I haven't opened it up yet. Wait, I might not be in the abdomen yet. So we'll pop this out. My finger's in the abdomen for sure. I can feel it. Lift up on that for me, please. So we should be inflating the abdomen now. And you can, well, let's see what we've got here. So we're putting our scope in now. Let's take that out. There we go. Okay, so now we can see the stomach there. And so we're going to be attaching, so that's gallbladder right there. Liver is up there, there's diaphragm. We'll try to do a bit of an exploratory, so that's looking at liver there. Now that is falciform fat up there. Diaphragm is there, and our attachment point is going to be right up about here, so I should be able to feel that up there. All right, so now I'm going to put in a couple of more ports just so I can, so what we'll do, come back over here, so hold on to that and drop it down a little bit. And I'm just going to put in another port up here, approximately where, so where's my rib here? Let's look over this way, see if you can see my finger poking in. There's my finger right there. So that's about where we're going to be. So just make a stab incision here so you can see the blade right there. And then I'll put a trocar. I don't want to poke too aggressively. So that's my next trocar there. And then hold on to that, please. And then I'm going to screw this in. And you'll see it poke into the abdomen there. Go ahead and remove that. And then I'll put another one in on this side over here.
Also, just a question. Do you stitch the stomach to the wall?
I do stitch the stomach to the wall, and I do that through, so I'm going to make a little mini laparotomy. Okay, so now I'll get a couple of instruments in here. So come around this side. So that's my grasper there. That's like an Alice tissue forceps. And I'll put in my Maryland dissector here. Now I'm going to use these two to identify the part of the stomach that I want to suture to the body wall. So grabbing onto the stomach there. Okay, so that's the part of the stomach that I want to attach to the body wall. So then I can pull out this instrument here, grab onto that, and then I'm just going to pull up a nice big bite of that, and I'm going to pull that up to the body wall. Now let's see if that is going to allow me to come up here. All right, so then what I'm going to do is I'm removing that port. I'll pull. I'm going to have to retrocarize that. So it's slipping out of the grasp of the Alice tissue forceps. I might have to get something a little bit more aggressive to hold on to it. And it'll, once we release the pressure on the abdomen, it will make it easier to hold on. I'm just seeing if I've got something else that's a little bit more aggressive. Okay. Maybe if I get something that's a little bit more mobile. Pretty good there. All right, so release this. All right, so now what I'm going to do is we'll switch over to the other view, the first view. Now I've got, you can see I've got here the port is right there, and we're going to relieve the pressure. Hold on to that, please, for me. Switch over to another blade. Can you guys see where I'm cutting? So it's just right there. Yeah. So I'm just going to switch over to a 10 blade. I'm going to make an incision in the body wall. And then I'll pull the stomach out through that incision. So my incision here is about 4 centimeters long. And we've got air leaking around the incision, which is fine, because we're going to open it right up. So this is a paramedian incision. You know what I might do is move the camera over there a little bit. Can I see? Zoom in. Okay, so now you can see better what I'm doing.
A couple of people watching from Texas and Portland.
Nice. ACVS is in Portland next year, or this year. I would love to attend. Come around that side. You want to switch sides with me, Sean? Now there's a chance that my grasper is going to drop the stomach, in which case I'll have to go in kind of blindly and retrieve it, because I won't be able to insufflate again, because I won't be able to generate the pressure. Let's get a couple of towel clamps ready, please. And it should be a little bit easier to pull it to the body wall because we've de-inflated. Okay, so there's the stomach right there. Got it. All right, so there's our stomach right there. And then just going to make a seromuscular incision in this stomach wall. Hold on to that. Pull that out there. Okay, can I get some proline, please? So that's seromuscular incision in the stomach wall. And then I'll grab a needle driver. Release that. Hold on a
Charles,
minute.
there's a question. Do you have the ability to get an SILS port? You can place over the Pexy site and do the same procedure through a single 3 to 4 centimetre incision.
I have not used SILS or SILS port. I understand that that is possible. The SILS port is going to be basically the same size as, let's just let that drop in a little bit. SILS port is going to be basically the same size as my incision. So I'm not sure if there's a big advantage to that, but I know that people certainly do use them.
And also, what part of the stomach do you attach?
So we're attaching the pylorus or the antrum.
And does the size of gastropexy incision matter when it comes to the strength of the gastropexy?
So generally we use about a 4 centimeter incision. And I'm not sure that the length of the gastropexy has been specifically looked at relative to the strength. Let's release that.
Yeah, all good. Thanks so much.
Let's go ahead and remove that, please.
This one?
Yep.
I've got a question about, can we do a gastropexy with the fundus?
You cannot do a gastropexy in the fundus because if you think about what is rotating with the GDV is the pylorus. And it's been shown that doing a gastropexy in the fundus is not effective at preventing GDV. Was that Dylan who asked about the Sills port?
UCLA climbing?
Right. Dylan is a vet student at, I believe at Texas A&M, and he always asks really good questions. And I assume that he's watching. Can I get some Privican, please? All right, so that's the gastropexy finished. I'm just going to stick my fingers in here, make sure that I don't have any hole. And now we can re-insufflate and then assess our gastropexy. So as soon as you didn't turn off the insufflator, did you? Okay.
It's going.
Good. No. Just come around here and see if I can get to the point that I can see. And is the light turned on still? Yes, it is. I'm just going to pull out my camera and clean the lens. So what I'll do is I'll have you, Camille, switch to the other view. All right, so there's my pylorus right there. That's my, I'm jiggling my gastropexy site here. Coming back down around, we can see the gallbladder there. Just making sure that I got what I thought I got. So that's coming down into the antrum there. The fundus is down there, so there's no evidence that I've twisted it, anything like that. Now this is an amazing laparoscope because you can look around corners with it. So I'm looking in front of the falciform. So you can look back and forth. So I'm just moving a little control on the laparoscope, and you can see that I can look up and down and left and right. So it's an articulated laparoscope. So coming back, looking at the stomach there, gallbladder. There's my pexy site there. And I'll look down the corner there. That's getting into some intestine down there. So I'm really happy with that. So that's exactly what I intended to do. And I think that we've achieved our intended result. So I'll just pull that out. We'll move that over here. We can switch back over to the other view, please, Camille. So I'm pulling out my port. Pull out the other port as well. You can turn off the gas. Yeah. So I'm just now injecting into the body wall. With mepivacaine, and I'll inject down here as well into the midline. Okay, and what I'll do is I'll let Aaron finish this up. So you're going to close just some simple continuous suture in here. You don't have to close that one except for the skin, and then we'll just close sub-Q over here. And I'll come over and make sure that I've answered all my questions. So the suture material that we're using is Prolene or polypropylene. I'll zoom out here so we can see what Sean is up to. And I'll come over and answer questions. All right, so going back up to the top here. Morning from Orlando. So lap assisted instead of FlexDex, because what I found is that the FlexDex is quite tedious and it can take me like an hour and a half. Even though I've learned how to use the device, I find that I can do the lap assisted much more quickly. And I don't think that there's a lot of difference in pain and recovery and that kind of thing. So I've gone mostly back to the lap assisted. Coming down, Brazil says hello. Gastropexy, we've already reviewed. To the wall, hello from Argentina, watching from Midlothian, Texas. Glad you're back. Hello from Portland. So pylorus or antrum, we already discussed that. You cannot do a gastropexy with the fundus. Suture material is polypropylene. Total hip replacement, we'll have to ask James to do that. He's the one who do the hip replacements here. UF is doing total hips now, great. Ohio State vet student. Our endoscope is made by Olympus, or our laparoscope is made by Olympus. It's a 3D laparoscope. I mostly operate on Tuesdays and Wednesdays. Today I'm operating, this week is Monday, Tuesday, but going forward it'll be Tuesday, Wednesday. I'm not sure if I've live streamed an inguinal tumor removal. We'll have to go back and do a search. And that's pretty much it. So thanks a lot for watching. I'm really excited to be back. And hopefully I'll be live streaming every day that I'm on clinics. So hope to see you guys again soon. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so that you'll get a ding on your phone the next time we live stream. And we will talk to you later.